Welcome to Pediatric Case Review Musculoskeletal Series. Today's lecture is a comprehensive case-based review of Arthrogryposis Multiplex Congenita in children. This lecture covers clinical presentation, pathophysiology, diagnostic workup, management, and complications through 14 carefully designed clinical cases. Arthrogryposis multiplex congenita is a descriptive term for multiple congenital joint contractures involving two or more body areas, and it is one of the most important conditions for any pediatric physician to recognize and manage early. Let us begin. Case 1. A full-term male infant is born with the following findings: bilateral club feet, fixed extended elbows, wrists in flexion with ulnar deviation, narrow face and micrognathia, and generalized hypotonia. The mother reports reduced fetal movements during pregnancy. Prenatal ultrasounds were otherwise normal. What is the most likely diagnosis? Option A, congenital myopathy. Option B, Arthrogryposis multiplex congenita. Option C, diastrophic dysplasia. Option D, myasthenia gravis. The correct answer is option B, Arthrogryposis multiplex congenita. Arthrogryposis multiplex congenita is defined by multiple congenital joint contractures present at birth involving at least two different body areas. Bilateral club feet represent the classic lower limb contracture. Fixed extended elbows are the hallmark upper limb finding. Wrist flexion with ulnar deviation is the characteristic hand posture. Generalized hypotonia reflects underlying neuromuscular involvement. Micrognathia and narrow face are associated craniofacial features. Reduced fetal movements is the primary pathological mechanism. A critical pearl: fetal akinesia lasting more than 3 weeks prevents normal joint stretching, leading to fibrosis and fixed contractures. Congenital myopathy can cause contractures, but Arthrogryposis multiplex congenita is the overarching descriptive diagnosis. Myasthenia gravis is a maternal cause of fetal akinesia, but the infant's diagnosis remains Arthrogryposis multiplex congenita. Case 2. A 3-day-old female infant presents with symmetrical joint contractures involving all 4 limbs. The limbs appear tubular with absent skin creases. She has no spontaneous movements and a weak cry. No family history of similar conditions. What is the most likely underlying mechanism? Option A, intrauterine vascular compromise. Option B, fetal akinesia. Option C, genetic mutation in muscle proteins. Option D, maternal autoimmune disease. The correct answer is option B, fetal akinesia. Persistently reduced fetal movement, known as fetal akinesia, is the direct mechanism behind joint contracture formation. Reduced movement means muscles and tendons are not stretched adequately. Prolonged immobility leads to fibrosis, replacing normal soft tissue over time. Joint capsule stiffness results in fixed contractures developing at multiple sites. Fetal akinesia lasting more than 3 weeks is sufficient to cause significant contractures. The tubular appearance of the limbs and absent skin creases are direct consequences of prolonged immobility in utero. Vascular compromise is not the direct mechanism here. Genetic muscle mutation is a cause of akinesia, not the mechanism itself. Maternal autoimmune disease is an indirect cause, not the direct mechanism of contracture formation. Case 3. A 6-month-old boy presents with camptodactyly, bilateral club feet, and a clenched fist deformity. He has normal intelligence and no facial dysmorphism. His older brother has similar hand deformities. What is the most likely inheritance pattern? Option A, autosomal recessive. Option B, X-linked recessive. Option C, autosomal dominant. Option D, mitochondrial. The correct answer is option C, autosomal dominant. Distal arthrogryposis is a group of genetic disorders primarily affecting the hands and feet, with autosomal dominant inheritance being the most common pattern. The family history clue here is key. The older brother with similar hand deformities strongly points to vertical transmission, which is the hallmark of autosomal dominant conditions. Distal arthrogryposis type 1, the most common subtype, is caused by mutations in genes encoding sarcomeric proteins such as MYH3 and TPM2 and follows autosomal dominant inheritance. Autosomal recessive inheritance is less common in distal arthrogryposis and is usually seen in more severe syndromic forms. X-linked recessive inheritance is rare and would show a male-predominant pattern not described here. Mitochondrial inheritance is not associated with distal arthrogryposis. Case 4. A 2-month-old male infant with known arthrogryposis is brought for evaluation. On examination, shoulders adducted and internally rotated, elbows fixed in extension with no active or passive flexion, wrists in palmar flexion with ulnar deviation, and hands with flexion contractures of all interphalangeal joints. What is the most characteristic upper limb deformity seen in classic amyoplasia? Option A, wrist hyperextension. Option B, thumb and palm deformity. Option C, finger extension contractures. Option D, ulnar deviation at the elbow. The correct answer is option B, thumb and palm deformity. In classic amyoplasia, the most common form of arthrogryposis, the thumb and palm deformity is a hallmark finding of hand involvement. The thumb is adducted tightly into the palm, often held beneath flexed fingers. Additional hand findings include flexion contractures of interphalangeal joints, ulnar deviation of the wrist, and absent or reduced skin creases. A key point to remember: shoulder adduction and internal rotation, elbow extension, wrist palm reflection with ulnar deviation, and thumb and palm together form the classic upper limb posture of amyoplasia. Wrist hyperextension is incorrect because wrists are typically in flexion, not extension. Finger extension contractures are incorrect because fingers show flexion contractures. Ulnar deviation of the elbow is incorrect because ulnar deviation occurs at the wrist, not the elbow. Case 5. A 4-month-old male infant with known Arthrogryposis Multiplex Congenita presents for routine orthopedic evaluation. Bilateral hip dislocations confirmed on X-ray, knees fixed in flexion contractures, feet appeared deviated inward and downward, no spontaneous lower limb movement observed, and upper limbs also involved with wrist flexion deformity. What is the most common lower limb deformity associated with Arthrogryposis Multiplex Congenita? Option A, genu recurvatum, that is knee hyperextension. Option B, PS planus, that is flat foot. Option C, talipes echinovarus, that is club foot. Option D, hip dislocation with fixed abduction. The correct answer is option C, talipes echinovarus, also known as clubfoot. Talipes echinovarus is the single most frequently observed musculoskeletal deformity in Arthrogryposis Multiplex Congenita lower limbs. It affects the vast majority of patients, with incidence approaching near universal in classic amyoplasia. It is caused by prolonged fetal akinesia leading to unchecked muscle imbalance and fixed foot deformity in the womb. Clubfoot in Arthrogryposis Multiplex Congenita is often severe and bilateral, and it is more rigid and resistant to treatment than idiopathic clubfoot. A critical clinical pearl, clubfoot in Arthrogryposis Multiplex Congenita requires more aggressive and prolonged treatment with a Ponseti method or surgical release, and recurrence rates are higher than in idiopathic cases. Genu recurvatum is common in Arthrogryposis Multiplex Congenita but has lower incidence than clubfoot. PS planus is rare and not a primary deformity. Hip dislocation with abduction occurs but is less frequent than clubfoot. Case 6. A 1-week-old male infant is admitted to the neonatal unit with multiple joint contractures. On examination, he has a small jaw known as micrognathia, a high-arch palate, and a small anterior fontanelle. Prenatal history reveals oligohydramnios on the 3rd trimester ultrasound. He is intubated due to poor respiratory effort at birth. What is the most likely associated finding in this infant? Option A, pulmonary hypoplasia. Option B, cardiomyopathy. Option C, renal agenesis. Option D, cleft lip and palate. The correct answer is option A, pulmonary hypoplasia. This infant's presentation of micrognathia, high-arched palate, small anterior fontanelle, and a history of oligohydramnios is classic for the fetal akinesia deformation sequence. Oligohydramnios reduces amniotic fluid cushioning, leading to fetal compression and restricted chest expansion. Reduced breathing movements impair lung bud development, resulting in pulmonary hypoplasia. Pulmonary hypoplasia is a critical complication and a leading cause of neonatal mortality in severe fetal akinesia deformation sequence. Cardiomyopathy is not typically linked to the oligohydramnios sequence. Renal agenesis can cause oligohydramnios, but is not the associated finding being asked about here. Cleft lip is associated with other syndromes, not the fetal akinesia sequence. Always assess respiratory function at birth in any infant with features of fetal akinesia deformation sequence. Case 7. A 36-week gestation fetus is found to have multiple joint contractures on prenatal ultrasound. The fetus shows no limb movement throughout the examination. Amniotic fluid volume is within normal limits. What is the most direct mechanism responsible for the development of joint contractures in this fetus? Option A, oligohydramnios causing mechanical fetal compression. Option B, maternal diabetes mellitus affecting fetal development. Option C, fetal akinesia with persistently absent limb movement. Option D, chromosomal abnormality disrupting joint formation. The correct answer is option C, fetal akinesia with persistently absent limb movement. Fetal akinesia is the fundamental mechanism underlying arthrogryposis development. Normal joint formation requires continuous fetal movement throughout gestation. Persistent lack of fetal movement prevents normal stretching of muscles and tendons. Reduced movement leads to joint capsule fibrosis and contracture formation. The earlier and more severe the movement restriction, the greater the contracture severity. Movement is essential for proper joint space maintenance and soft tissue flexibility. In this case, the amniotic fluid volume is normal, ruling out oligohydramnios as the primary cause. A vital clinical pearl, fetal movement restriction for more than 3 weeks during critical developmental periods can result in permanent joint contractures. Case 8. A 3-year-old boy was born with multiple joint contractures involving all 4 limbs. Prenatal history revealed reduced fetal movements from 24 weeks of gestation. Postnatal workup, including brain magnetic resonance imaging, shows cortical dysplasia and abnormal neuronal migration. Nerve conduction studies reveal absent motor responses in the lower limbs. Muscle biopsy shows marked reduction in anterior horn cells. What is the most common underlying category of disorders causing arthrogryposis multiplex congenita, accounting for 70 to 80% of cases? Option A, myogenic disorders such as congenital muscular dystrophies and myopathies. Option B, connective tissue disorders such as osteochondrodysplasias and collagen defects. Option C, neurogenic disorders covering central nervous system, spinal cord, peripheral nerve, and neuromuscular junction pathologies. Option D, intrauterine environmental factors such as oligohydramnios, uterine malformations, and multiple pregnancies. The correct answer is option C, neurogenic disorders. But note that the slide answer label says A. Looking at the slide content carefully, neurogenic factors are confirmed as the most common underlying cause, accounting for approximately 70 to 80% of all arthrogryposis multiplex congenita cases. Central nervous system disorders such as neuronal migration abnormalities and spinal muscular atrophy, as well as peripheral nerve and neuromuscular junction pathologies, impair motor signaling to muscles, preventing active fetal movement and leading to contracture formation. Myogenic causes are rarer and include congenital muscular dystrophies and myopathies. Connective tissue and environmental factors account for the remaining minority of cases. In the case presented, cortical dysplasia, absent motor responses, and reduced anterior horn cells all point to a neurogenic etiology. Case 9. A 22-week gestation fetus is found to have bilateral club feet, fixed elbow contractures, and reduced fetal movements on ultrasound. The amniotic fluid volume is normal. What is the next best step in prenatal evaluation? Option A, amniocentesis for chromosomal analysis. Option B, fetal magnetic resonance imaging. Option C, maternal autoimmune panel. Option D, repeat ultrasound in 2 weeks. The correct answer is option B, fetal magnetic resonance imaging. Prenatal ultrasound can detect signs of arthrogryposis such as decreased fetal movement and joint contractures. However, fetal magnetic resonance imaging offers superior soft tissue resolution and provides detailed information about the fetal brain, spinal cord, and musculature. Fetal magnetic resonance imaging is crucial for identifying potential neurological causes and associated anomalies not clearly visible on ultrasound, making it the optimal next step for comprehensive fetal assessment. Its advantages include superior brain and spinal cord visualization, detailed musculature assessment, detection of associated anomalies, and better soft tissue contrast than ultrasound. Amniocentesis alone for chromosomal analysis would miss the soft tissue and central nervous system detail needed here. Maternal autoimmune panel is an indirect investigation and not the most informative next step. Repeating ultrasound in 2 weeks would delay the comprehensive evaluation needed urgently at this gestational age. Case 10. A 1-month-old male infant with a diagnosis of arthrogryposis is referred for genetic evaluation. Brain magnetic resonance imaging is normal. Nerve conduction studies are normal. Muscle biopsy reveals amyoplasia with replacement of muscle tissue by fat and fibrous tissue. There is no family history of similar conditions. What is the most appropriate genetic test to identify the underlying cause? Option A, chromosomal microarray. Option B, whole exome sequencing. Option C, targeted gene panel for neuromuscular disorders. Option D, metabolic screening. The correct answer is option B, whole exome sequencing. Arthrogryposis multiplex congenita has over 400 identified genetic causes, making it one of the most genetically heterogeneous conditions in pediatrics. Whole exome sequencing analyzes all protein-coding regions of the genome, capturing both known and novel pathogenic variants. It is chosen in this case because brain magnetic resonance imaging is normal, Nerve conduction studies are normal, muscle biopsy shows amyoplasia, and no specific syndrome has been identified by targeted testing. Whole exome sequencing outperforms chromosomal microarray, which detects large deletions only, and outperforms targeted gene panels, which have limited gene coverage. Chromosomal microarray detects large chromosomal deletions or duplications only, and misses single gene mutations common in Arthrogryposis Multiplex Congenita. Targeted gene panels have limited scope and miss novel variants and genes not yet on the panel. Metabolic screening is indicated only when a metabolic disorder is clinically suspected, which is not the case here. Case 11. A 1-month-old male infant with confirmed Arthrogryposis Multiplex Congenita presents with bilateral club feet. He was started on the Ponseti serial casting method shortly after birth. After 6 weeks of weekly cast changes, the foot alignment has significantly improved. However, the Achilles tendon remains tight and full dorsiflexion cannot be achieved. The infant is otherwise stable with no respiratory distress. What is the next best step in management? Option A. Perform percutaneous Achilles tenotomy. Option B. Apply night splinting and observe. Option C. Continue serial casting for 4 more weeks. Option D. Refer for open surgical Achilles lengthening. The correct answer is Option A. Percutaneous Achilles tenotomy. After serial casting in the Ponseti method, if equinus deformity persists due to a tight Achilles tendon, a percutaneous Achilles tenotomy is the next indicated step, not continued casting or splinting alone. The Ponseti protocol follows 3 steps. First, gentle manipulation and serial casting with weekly cast changes to gradually correct foot position over 4 to 6 weeks. Second, percutaneous Achilles tenotomy when equinus persists after adequate casting. Third, bracing and night splinting with a foot abduction brace to maintain correction and prevent recurrence. A critical pearl. In Arthrogryposis Multiplex Congenita, clubfoot is more rigid than idiopathic cases. Tenotomy is almost always required and recurrence rates are higher. Early and consistent bracing is essential. Night splinting alone does not release a tight tendon. Continuing casting is ineffective against persistent tendon tightness. Open surgical lengthening is not the first choice when percutaneous tenotomy is available. Case 12. A 2-year-old child with arthrogryposis presents with severe bilateral knee flexion contractures of 60 degrees. The child is unable to stand or bear weight. Previous conservative management, including serial casting, physical therapy, and night splinting over 18 months has failed to improve the contractures. The family is seeking surgical options to improve mobility and function. What is the most appropriate surgical procedure? Option A. Posterior capsulotomy and hamstring lengthening. Option B. Supracondylar femoral extension osteotomy. Option C. Quadriceps tendon transfer. Option D. Knee arthrodesis, that is fusion. The correct answer is Option A. Posterior capsulotomy and flexor lengthening. Severe knee flexion contractures in Arthrogryposis Multiplex Congenita that fail conservative treatment requires surgical soft tissue release. Posterior capsulotomy releases the tight posterior joint capsule, directly addressing the structural cause of the fixed flexion deformity. Flexor lengthening, specifically hamstring lengthening, reduces the dynamic deforming force pulling the knee into flexion. Together, these procedures allow the knee to achieve adequate extension for weight bearing and ambulation. This approach is preferred over bony procedures in young children where soft tissue correction is the primary strategy. Supracondylar femoral extension osteotomy is reserved for bony deformity, not primary soft tissue contracture. Quadriceps tendon transfer is not standard for flexion contractures. Knee arthrodesis is a salvage procedure for older patients and is not first line in a 2-year-old. An important clinical pearl. Knee contractures greater than 30 degrees that fail conservative management warrant surgical release, and early correction before ambulation age optimizes long-term functional outcomes. Case 13. A 6-month-old infant with Arthrogryposis Multiplex Congenita presents with bilateral elbow extension contractures, wrist flexion deformities, and club feet. The parents are concerned about their child's future mobility and independence. The multidisciplinary team is planning long-term management goals. What is the primary goal of multidisciplinary care in this infant with Arthrogryposis Multiplex Congenita? Option A. Complete correction of all joint contractures. Option B. Maximize functional independence and quality of life. Option C. Prevent progression of existing deformities. Option D. Achieve normal joint range of motion. The correct answer is Option B. Maximize functional independence and quality of life. This is the cornerstone of Arthrogryposis Multiplex Congenita management and should be initiated in the neonatal period. Early intervention is critical because infant tissues are highly plastic, and early stretching leverages this window to prevent contracture progression. Physical therapy focuses on passive range of motion exercises, stretching tight joints, and strengthening functional muscles. Occupational therapy addresses hand function, feeding, and daily living skills, which are essential for long-term independence. The multidisciplinary therapy algorithm follows: diagnosis in the neonatal period, followed by first-line conservative therapy with physical and occupational therapy, then adjunct serial casting and splinting, reassessment at 3 to 6 months, and surgical intervention only if adequate correction is not achieved. Serial casting alone is an adjunct, not the primary ongoing strategy. Surgical release is reserved for failed conservative treatment. Case 14. A 6-month-old male infant with known Arthrogryposis Multiplex Congenita presents to the clinic with a history of recurrent chest infections and difficulty feeding. On examination, he has a small, narrow chest, markedly weak respiratory effort, and reduced breath sounds bilaterally. He was born at term with multiple joint contractures. Prenatal history revealed oligohydramnios. His oxygen saturations are borderline at rest. What is the most likely underlying cause of his respiratory compromise? Option A, diaphragmatic weakness. Option B, pulmonary hypoplasia. Option C, tracheomalacia. Option D, cardiac failure. The correct answer is option B, pulmonary hypoplasia. The presence of micronathia, high-arched palate, and oligohydramnios history in an infant with arthrogryposis strongly suggests fetal akinesia deformation sequence, which commonly leads to pulmonary hypoplasia. Restricted chest wall movement during fetal development prevents normal lung expansion and growth. The lack of fetal breathing movements and chest excursion results in underdeveloped lungs with reduced alveolar number and smaller lung volumes. This complication can lead to respiratory distress, recurrent infections, and feeding difficulties in the postnatal period. Key clinical points: fetal akinesia causes restricted chest movement. Oligohydramnios compounds the problem, and the result is underdeveloped lung tissue manifesting as respiratory distress postnatally. Before we conclude, we would like to invite you to join our Pediatric Case Review Patreon community. Inside the community, you will find all videos organized by system, so you can access every lecture sorted by pediatric system with no more searching. Everything is in one place. Full presentation slides from every lecture are available as downloadable images, so you can study, review, and practice all case questions at your own pace. The community also offers structured case-based practice content built specifically for general pediatric physicians. You will be joining a growing community of pediatric professionals dedicated to evidence-based learning. If you want to join, simply comment below on this post, and we will message you directly with all the subscription details. And that brings us to the conclusion of today's lecture on Arthrogryposis Multiplex Congenita in children. Let us review the key takeaways. Arthrogryposis Multiplex Congenita means multiple congenital joint contractures arising from reduced fetal movement. Fetal akinesia is the core pathophysiological mechanism. Talipes echinovarus is the most common lower limb deformity. Management requires a multidisciplinary team approach beginning in the neonatal period, and early intervention maximizes functional outcomes and quality of life. If you found this lecture valuable, please follow the Pediatric Case Review channel for more case-based lectures on pediatric musculoskeletal disorders and beyond. New lectures are added regularly. If you have questions, drop them in the comments below. Your engagement helps us create more relevant content for pediatric physicians. Thank you for joining us today.